Good afternoon. We had an exciting morning, and we hope to continue at a high level. This is a session where we were joking we have more moderators and speakers, but we will share the moderation, the four of us, all friends. And it's a very good session, a lot of controversies as always in this meeting and in the others. And I start, and we share the presentation. The first speaker is Karel Leroux. Giving a talk about a brief history of time in the pharmacotherapy era. Please, Karel.
Well, thank you very much for this opportunity. And I start with my favorite author, Bill Bryson, a short history of nearly everything. So we're going to go through, this brief history. And I'm really going to give you my perspective, on this. These are my conflicts of interest, and I work with lots of different companies because what we want to do is we want to move away from this idea about eating less and moving more as a weight loss treatment, and we actually want to remove the rock from Sisyphus in treating the disease of obesity. And I think this really encapsulates the brief history of pharmacotherapy. It's when we understood that we no longer have to help our patients to actually behave better. And that's how pharmacotherapy was considered. Now we actually understand that all the pharmacotherapy it's treating the disease. And therefore, it has to be without effort to be effective. Now, if you look at the history from the 1960s, if you did an open gastric bypass in the 1960s, the patient would have lost exactly the same amount of weight than if you do a laparoscopic bypass today. So the efficacy of surgery has not changed over the last 80 years. Or 60 years, rather, if my math leads. But what has, of course, changed is the safety. So surgery is incredibly safe now in comparison to where it was, but the efficacy has not changed. The same is true for lifestyle treatment. If you had a lifestyle treatment in the 1960s, you would have lost exactly the same amount of weight than if you have a lifestyle treatment today. With all the apps and all the artificial intelligence in the world, the efficacy of lifestyle change is still going to be between 5 to 10%. But what's happened with pharmacotherapy is that we were incredibly rubbish for many, many decades. But suddenly, things have changed. And because it's changed only in the last couple of years, we've suddenly have seen this ability to scale the treatment. But if you go back even further and you actually look at the history of discovering the gut hormones, this shows you, even going back to 1905 and 1902, when these gut hormones were discovered. And of course, you will know better than anybody that the gut is the largest endocrine organ, producing the largest number of hormones. And you can see that every time you have a meal, you actually have a dynamic function test because all these gut hormones are in play. And understanding how bariatric surgery works is also understanding how these gut hormones are changed afterwards. And although the gut hormones do not explain everything about bariatric surgery, it certainly has allowed us to understand how the gut talks to the brain. And whether or not you use the distal gut hormones such as PYY, GLP-1, oxyntomodulin, these are the exact same hormones that are now being put into medication, or you use the neural circuits into the vagus, all roads lead to Rome. And I think that has been a massive benefit, from the history of understanding pharmacotherapy, because suddenly we understood what organ it is we are treating when we treat obesity. For so many years, people thought the organ that they were treating were adipocytes. And adipocytes are very active, a mass of very active cells and an organ on its own right. But adipocytes are not the cause of the disease of obesity. It is the signs of the disease of obesity. The cause sits in the neural space. So we now think of obesity as a neurological problem. And of course, surgery is the best treatment for the neurological disease that is obesity. Because when we measure what happens after surgery, we see that those effects happen in the hypothalamus, in the area postrema, and the nucleus tractus solitarius. So when you do an operation, the effects are actually happening in exactly the same space where the disease of obesity is caused. So what have we learned from the history of pharmacotherapy? And what we now can see is if we radio-label semaglutide or liraglutide or zenagamtide, anything that you want to radio-label, and you inject it into the periphery of a rat, and you then measure where that peptide binds, that drug binds, you will see it binds exactly in the same spaces where bariatric surgery works. These medications do not bind the cortical areas of the brain. They do not make the rats or the humans more intelligent. They not make them more motivated. They merely treat the disease of obesity. So it's been a windy road that we see, but let's now just focus on the GLP-1 receptors agonists. And you can see the discoveries back in the 1960s, as I've illustrated. And remember, the first time these drugs were licensed by the FDA was in 2005. Right? We have more than sleeve years of history of data on these drugs. And just to put that in context, that was the same year that sleeve gastrectomy was proposed as a standalone procedure. So the amount of data that we have on sleeve gastrectomy and the amount of data that we have on GLP-1 agonists are the same length of time. And what has happened is initially the road was very slow. It was difficult, to actually get the new treatments. You can see semaglutide, arriving on the scene. First liraglutide, then semaglutide. And of course, in 2021, we had this explosion of ideas. So first semaglutide 2.4 milligrams was licensed, then tirzepatide was licensed. And this year, we're going to see data from phase 3 studies on orforglipron, survodutide, cagrisema, retatrutide, all at once. Okay? And these drugs are going to change, the history, going, in the short term, but also going forward. And this is Ricardo Cohen's slide, where he took the retatrutide phase 2 data and superimposed it on his own bariatric surgery data from the MOM study. And you can see when people now talk about the gap being very narrow, is there are no longer a gap. Right? When we look at retatrutide and the data that is at least in a press release, we're talking about 30% weight loss on average. Right? 30% weight loss on average, that means there's going to be about 10% of people, I haven't seen that data, but it's going to be about 10% of people that's going to lose half of their body weight with retatrutide. There's going to be about 10% of people that don't respond to this drug. That's exactly the same Gaussian distribution that we see when we look at bariatric surgery. But what have we learned from our short history is that medications are incredibly effective, but patients stop taking the medications. You could see that at 1 year, more than half of people who responded to the drugs have stopped the medications. And that tells us more about, how we view the disease of obesity rather than the efficacy of the medications. And that's something that I think we need to address. And I think that's really one of the major benefits that we have from surgery, because the patients can certainly stop the drug that I've prescribed, but the patients cannot undo the gastric bypass that Dimitri has done. And therefore, this is a chronic disease that needs chronic treatment, and surgery remains the best chronic treatment that we have. But what has medication also done is medication is shattering the goals that we had. We thought our job was weight loss. We thought our job was percentage weight loss. We measured our success in either 10%, 15%, 25% weight loss. And what we're now seeing with these medications, when the trials are coming up, is that there's a disconnect. And let me just quickly talk you through this slide. On the x-axis, we have the number of patients in the SURMOUNT-5 study. This is semaglutide and tirzepatide. And on the y-axis, we have the percentage of patients that go to a low cardiovascular risk state, where they have normal glycemia, normal blood pressures, normal lipids. And what you will see, percentage weight loss in the blue line at the bottom is less good than actually achieving a target such as a BMI of 27 or a waist-to-height ratio of 0.53, as illustrated by the line. So that means that if you have a good gastric bypass, and you take somebody down from a BMI of 50 down to a BMI of 35, it may be beneficial for the patient to actually go to a lower threshold, in the same way as if you do a good gastric bypass on somebody with a hemoglobin A1C of 10, and they come down to a hemoglobin A1C of 8%, you're not going to say, that's a good job because I've got 2% reduction. You're going to say, let's add a medication and get you to the target, which is 6.5. So ultimately, what we see is, if we just think about all the patients with type 2 diabetes, a small number is having surgery at the moment. If we think about medication, that may be tenfold higher, but there's going to be 20% of people that don't respond. And you can see the non-responders in surgery, the circle is larger than all the people having surgery today. So therefore, that is the opportunity to work together. So allow me to conclude and suggest to you that obesity medications will treat the disease of obesity. These are not weight loss drugs. These are not appetite reduction drugs. They are treatments for the disease of obesity. They will keep the disease under control as long as they are continued. And of course, they will complement and not compete with surgery. Thank you very much.
Thank you very much, Karel. As always, very balanced presentation. Thank you so much, very clear. Questions from the audience? Please. Can you switch on the microphone, please?
Seems to be, no, it's on. Karel, always a great talk. I wanted to ask you, you showed that great slide with the animal model where the medications and bariatric surgery lit up the same parts of the brain. In my clinical experience, it's not always universal, but there's a difference. People with medications will often say, my drive to eat has reduced, whereas people with bariatric surgery will say, some will say that, but a lot will say, my drive is still there, yet I can't eat as much. Yeah. How do I explain that?
So, and you're addressing a question, really that I think Alex and others are going to answer, because for the most bizarre reasons, these treatments are additive. I remember when Alex first said to me he wants to do the study where he's going to combine medication with surgery, and I said to him, you're wasting your time. That is such a stupid idea, right? And I was so incredibly wrong. So what it shows is it works in the same parts of the brain, but it actually has complementary effects. And we actually see that now with combining medications. So for example, when we combine amylin medications with GLP-1 medications, we see that they bind the same regions of the brain, but the actual nerves that light up are different. And that's why we see that they are additive, not as additive as surgery plus medications, but, so I think that's the way to understand it. The neurons that are activated can be different, even though it's in the same region of the brain.
Set? All right. Thank you. Thank you very much, Karel. Our second speaker is Alex Miras, who is an endocrinologist from the UK. He will be talking about what do we know about multimodal treatment from RCTs.
Great. Well, again, very much thank you to the organizers of this meeting, and I would like also to congratulate IFSO for actually really leading in this field of combination treatments. I would also like my medical colleagues from other organizations to start thinking in the same way and not forgetting all of the benefits and lessons that we've learned from bariatric surgery, and I will show some evidence of that in a second. So I will just be focusing on two RCTs that are demonstrating a specific point. You're going to see a few more of those RCTs coming out pretty soon. So this is exciting, considering that, unfortunately, at the moment, the amount of research that's being performed in this field is not as high as we would like it to. So this is what I was referring to, some of the work led by Polina Salminen. And here we've got some really nice consensus definitions of what is suboptimal response to surgery. We had to come up with a number. The number that we came up with was less than 20% total body weight loss, but also no improvement or low, modest improvements in a significant obesity-related complication. And also we've split it to early suboptimal response and late suboptimal response. So we will see that after surgery, which we also will see after medications. What do we do next? Important to go always back to basic principles, right? So look at life factors surrounding the patient. Can we do anything about them? It is often that we cannot do much about those, and that is fine, but we need to go back and address them. I upset a few surgeons last year when I said that revision surgery is dead. I'm probably upsetting you as well. It just does not seem to be worth its while. And I'm not talking about converting a band to a sleeve or a bypass, but talking about playing around with the gastric bypass, trying to find ways of improving the outcomes. And I have done some of those studies. They do not look promising. So, and again, this is perhaps my own opinion. I think we are better off as surgeons, or you are better off as surgeons doing more primary operations and more significant, important revision operations to correct things. But in order to maximize the benefits of surgery, I just don't feel that the data are there to support us. So let's see what pharmacotherapy can do. Again, as Carl said, well, Carl came up with this data, and then when we worked on those data, he told me it was a stupid idea to do the trial that I did. So this is correlation data, which demonstrates that those that did suboptimally after bariatric surgery back about 20 years ago had lower levels, plasma levels of the hormones that are implicated in the mechanism of action of surgery. So we said, possibly in a simplistic manner, okay, so what if we make up this GLP-1 gap that you are seeing on the screen? Take suboptimal responders and push them up to the levels of good responders in order to match the outcomes. So that led to the first randomized controlled clinical trial that supported this complementary treatment that we are discussing today. So what we did is we took 80 patients who had previously undergone gastric bypass or sleeve gastrectomy. And remember, these people had obesity, but they also had diabetes. And we defined suboptimal response semi-randomly as to a relapse of the patient's diabetes, okay? There were practical reasons for this. The only drug that was available at the time for us to play with was liraglutide at a dose of 1.8 milligrams. So we were a little bit restricted as to what we could do, but we pushed on onwards anyway. So 2-to-1 randomization, and we treated people for 6 months. These were the baseline characteristics. Again, predominantly women, but quite a few men as well. You will see HbA1cs of about 7.5 to 8% or so, and body mass indices of approximately 37. Now, pay attention to, it might be a little bit small here, but pay attention to this, which says that the weight loss that these people had achieved after surgery in both the placebo and the liraglutide groups was around 20-21%. That's really not bad, okay? So we are not looking at really suboptimal responders. They had done pretty well, but the diabetes had come back. And what we found, perhaps to our surprise to a certain degree, was that liraglutide at a dose of 1.8 milligrams worked as well as it would have done in people who have never been operated before. It looks as if these medications, liraglutide was the first one we used, cannot see whether the patient has had an operation or not. Now remember, we did not measure GLP-1 levels in this trial. We assumed they were low, but they might not have been. So we can discuss perhaps later on as to why we are seeing what we are seeing, which is in the short term, in the 6-month period, a reduction in HbA1c of about 1.1%, and a reduction in weight of about 6%. So it worked. But look at this. Even in this mix of surgery plus medications, we still see the same heterogeneity of response that we see with surgery and that we see with medications. So on liraglutide, there were people who lost 20% of their body weight on top of what they had lost after surgery. Remember, these are people with diabetes, yeah, which are difficult to treat. So, and there were people who put on weight on liraglutide. So typical response here, heterogeneity of response. And believe me to mention that even though we were underpowered to make any major conclusions about this, there were no differences with regards to the effects of liraglutide as to on people with gastric bypass or people with sleeve gastrectomies. And now we have got this trial, which was done by Rachel Batteram's group when she was at UCL. And what she did and her group did is they used liraglutide at 3 milligrams in this RCT. So they used Saxenda in people with obesity, and they had done, in terms of response, they were pretty suboptimal responders. So have a look at this slide here. They had lost about 7% of their body weight after surgery. I appreciate this is quite uncommon. But they found those people with true suboptimal responders, and they also had suboptimal response in terms of GLP-1s. And what did they see? Very much aligned to our results. This is the effects of Saxenda over the course of 6 months. So people lost about 8% or so of their body weight, which is probably a little bit more than what we would expect Saxenda would do at this point in time, raising perhaps the question as to whether the effects are not just additive but synergistic. Might be stretching things here. And again, we are seeing this, again, very nice heterogeneity response even on Saxenda after surgery. But again, we are seeing that the medication works as if it doesn't recognize whether the patient has had an operation or not. Again, I want to congratulate IFSA for this work that they have done, which is to, first of all, perform a systematic review of pharmacotherapy around the time of bariatric surgery, before and after. This is a beautiful piece of work, but I'm saying that because I'm the senior author. However, there is also a consensus statement, which is also reads very well, and it summarizes very nicely the discussions and the conclusions, but also very importantly, the unanswered questions. We have concentrated on people who have not responded well after surgery, but this doesn't mean that medications cannot be used in people who have responded well after surgery, but they have not achieved the improvement in their obesity-related complications that we would like them to achieve. We don't have data for that, but I'm sure that at some point we will. And look out over the next few days. Janine Makaronidis, who is a good colleague of mine from UCL, has just had the paper accepted when she used semaglutide, Wegovy, after surgery. Published in Nature Medicine. Is going to come out hopefully in the next few days. And again, hopefully confirming what we have just presented. Thank you for listening.
Thank you very much, Alex, for this talk, and the floor is open for questions or comments.
It is not possible for there to be no questions. I'm sure you have got plenty of questions because this is a major problem. So this is your chance to disagree, agree, or ask difficult questions. Yeah, there we go.
I'll just go. Thank you for the very interesting presentation. I was wondering, do you think it will work if patients after bariatric surgery still eat like a very small portion? Will it have an effect, an additional effect to use the medicine?
So, are you saying they're not eating much, but they have not responded
Exactly.
well?
Yeah.
Well, first of all, if you want to be certain about what people do after surgery or medications, you need to actually measure it, okay? Now, so that is one caveat of everything that we do in appetite research and obesity research. So that is a big limitation, and what people write on the form sadly does not represent what happens in reality. And that happens both for people with obesity and normal weight people. We all underreport how much we eat. The best way I can explain this is that whatever someone is eating is enough to keep them at the weight that they are at. It doesn't matter necessarily what the amount is. So the percentage reduction is still going to be meaningful.
Thank you.
So,
You agree?
Alex, so if you have patients, for example, that take medications and don't want to take medications anymore, you then do surgery, and you then have to go back to them and say, actually, now you have to restart the medications. Do you think they are more or less likely after bariatric surgery to take medications, such as semaglutide or tirzepatide? Because, the reason they had surgery is because they don't want to take drugs.
Yeah.
You ask for difficult questions, right?
Yeah. Easier for diabetes. So what we found is that when we were using these medications for the Gravitas trial, where we were chasing more diabetes than the weight loss, it was a bit more acceptable, okay? Now, what happens in obesity, it's difficult to know whether this is different, but it's the way that it is presented to them, right? If you present it in the oncological fashion, which is to say, we gave you chemotherapy before surgery, it did some decent work, but we thought surgery would be better. And then you say, but unfortunately, either the cancer is back or we haven't treated it fully. If we know what we are treating, which is the health complications, which we mentioned, rather than just the weight. So if we've got a clear target as to why we're doing this, I think people are more likely to understand and accept that.
Thank you. Torsten Orbers from Sweden.
Any more difficult questions?
Yeah. Mechanistically, with Addy. Yes. But we're playing on the same violins in a way, but we're playing in different ways. Can you tell something about
Mechanistically, probably the best explanation that I come to you with is that when we use these medications, we increase the area under the curve of GLP-1. So it might be simplistic. So what I would say is that after surgery, you get the spikes of all of these hormones during the meals. But in the fasting state, the concentrations go back to baseline. So perhaps what we're doing is we are filling in the gaps between the spikes, okay, to enhance the effects of surgery. That's as best as I can.
Alex,
explain.
I have
Yes.
the opposite question of Karel. If a patient do not want to have surgery,
Yes.
and they go to medicine,
Yes.
they are not responders, do you think they will be more likely to be operated after?
Yes, because now they have become medicalized. And I think, again, I said that earlier in the morning, the moment people start becoming medicalized, and that's the right thing to do for people who have the disease of obesity, We just, we're talking, again, and if we use the parallel of cancer, if our discussions are made in that way, people will listen. So we gave you did not want to have surgery, we're giving you chemotherapy instead, we think that's going to work well for your condition. That is fine. It's all about the language and the explanation that we are using, I think. Good, thanks.
Thank you, Alex. Excellent. The next speaker is Pauliina Salminen, Professor of Surgery in Turku and our current President of the European chapter. And again, she will highlight why we should not compare apples and oranges.
Thank you very much for the kind invitation, and good afternoon on my behalf. And this is kind of repetition, but I think we keep on saying it because every single time we read abstracts for a Congress, we go through, and of course now we can partially use AI to take out the no-no words. But the list of no-no words that are being used in the abstracts is very long. So we do have to consider the words and the language we use, and I think 2 reasons. Of course, the definitions are important because without having standardized definitions, it is impossible to compare any trials or any studies. So we actually have to know what we're talking about. And in the disease of obesity, the stigma is such a major issue. So we really have to focus on using non-stigmatizing language. My disclosures, nothing relevant for this study outside that I was part of the IFSO Global Consensus meeting that was in February. And I left that date there because I think it's going to be interesting to see in a few years that how well have we been able to implement the new terminology. So, and how we should actually do that. And I first want to show you the study that our Dutch colleagues did with actually Ronald being part of the group. So when the ASMBS reporting standards came out in 2015, they are quite long and maybe a bit complicated in my mind, but they looked at the 5 years after these standardized reporting guidelines were published. So how often they were used? Anybody want to guess? What is the percentage of papers? Like you think about how many papers MBS is produced annually within the metabolic bariatric surgery field. So just percentage. Somebody? Oh my God, that's positive. Wonderful. I love positive people. So 0.067 were actually used in these. So this means that it doesn't really matter if we write a paper or we write a guideline if we don't implement it. This is the same for every RCT result. And like I said earlier, yesterday was that it actually is a median of 17 years, so 17, for an RCT result to be implemented in clinical guidelines. So this is not a sprint, this is more of a marathon, and that's why we keep on having these presentations every year to show you the terminology and definitions that we all should aim to use. So I will quickly run through this, our IFSO consensus that had 15 definitions, and it was first initiated in September 2023 with a fancy book too, but that's why I want to have the date because I think we need to look at this implementation. So there were some other statements. I'm not going to go into that. So only the ones on definitions. A very multidisciplinary group in Hamburg, or actually outside Hamburg, in the middle of nowhere. So we could not run away from there. Everybody was working really hard for 2 days. So I want to start off with the really clear no-no words. So the top list of what we correct from abstracts. So in English, sorry, there's a typo, so non-stigmatizing terminology. Please always in English use patient first language. So it's patient with obesity, not obese patient. And it is severe obesity, morbid, has a very negative connotation. So do not use the word morbid. Do not use the word super obesity or super obesity. That is very, very stigmatizing and has an extremely negative connotation. So instead, you can say severe obesity and use the classes for obesity. So class 2, class 4, class 5. So never, ever write morbid or super obesity, okay? And never say failure. Because failure, when you say failure, that just means that, the patient failed, that they're the active participant in failing. So do not say failure. Failure is definitely a no-no word. So it does increase stigma. You may be a non-responder, and that's why we actually came up with suboptimal initial response or recurrent weight gain, and I will go back to that, not even insufficient weight loss. So, because remember, language does shape stigma and care quality. So this was a Delphi study. There's me and Gerhard and Lee Kaplan. Lee Kaplan was really helpful in creating these definition and reporting standards. And the mean consensus level was actually very high. And I just want to show you, because you see the reporting definitions there, and if somebody notices, there actually is already, or in this consensus paper, it still says AOM, so anti-obesity medications. We did the consensus next year in Vienna, and it was actually the patient representatives that made the final decision that they would want it to be obesity management medication. Because, for example, for hypertension, you do have anti-hypertensive medications, but hypertension as a disease is not stigmatized similarly to obesity. So that was the rationale, and currently it is obesity management medications, and hopefully that won't change. So going into the reporting definitions, so 100% consensus that a suboptimal initial response, so remember, no failure, no insufficient weight loss, it is suboptimal initial response, is demonstrated by either inadequate weight loss or by unusually modest improvement of the disease. So 100% agreed on that. And again, not very surprisingly, a late postoperative clinical deterioration, either recurrent weight gain or worsening of a significant obesity complication. All of these actually highlight the fact that it is not only weight loss, it is also a more composite endpoint type of ideology. Number 3 is kind of a no-brainer, that it can vary widely from patient to patient, and then still somebody disagreed. That's not 100% consensus. That kind of surprises me still. The baseline weight, I think, is a crucial idea. Yesterday, we showed the if-so position statement on patients that had a good response after OMMs and having the criteria to transit to metabolic bariatric surgery as the initial baseline weight. So it was a very high consensus on that everybody should report the baseline weight is the weight determined before starting any preoperative weight reduction. Because if you do that on a day of surgery, or you do that in the start of the process, or somewhere in the middle, you understand that when we compare different trials and look at the weight loss, it is a very different issue. And you have to remember why this logic, and I think it's clear. Without the surgery, the weight loss would not be sustainable. So the surgery actually makes that preoperative weight loss sustainable. The number 5 and number 6, I'm not going to go into detail. That is for the OMMs, whether you use it before and after. The initial surgical weight loss was set to be assessed at first 2 years. So 2 years was the time frame for assessing the initial surgical weight loss. Then going forward, there's a lot of mixed terminology when using revision surgery. Like Alex, well, you said that, it's gone, but we will still probably need some. but it's the idea is that conversion actually means that you introduce additional mechanisms. So, for example, you convert a sleeve gastrectomy to a Roux-en-Y gastric bypass. That's conversion. But if you do revision, you actually try to enhance or optimize the effectiveness of that previous operation. So like Alex said, to play around with the bypass, that would be a revision. Then again, of course, complication treatment is very different. So I will finalize with the idea that you cannot actually, I want to say that please don't say that the procedures are named due to their mechanisms of action. So it is not restriction, malabsorption, and we don't want to have malabsorption. Remember, that's hypoabsorption. So do not name the procedures according to their alleged or thought mechanisms of action. So please describe the procedures by their anatomical features. And I will conclude with this slide, which I think Alex already showed. And this was a really long discussion because categorical variables, in my mind, are always problematic. Because if it is like, 20% is good, 19% is bad, come on. That's not true. But then again, in order for us to, for example, compare trials that would have suboptimal initial clinical response, then we would have to have that definition, and in order to assess the outcomes and compare different trials on how to choose the patients. And again, for 30% for the late post-operative clinical deterioration. So to implement this, that's why we keep on repeating this. That's why we have the list when you submit your abstract. That's why we have submitted the wordings to all the journals that should use that. But I've still, just a few weeks ago, saw a very high-class journal say obese patient. So that is something that we just have to keep on implementing. So this is the group from Hamburg. Thank you very much, and thank you on behalf of the European chapter. Remember our application for our committees, and see you in Toronto and Munich. Thank you very much.
Thank you. Thank you again, Paulina, for reminding us of all this. Are there any questions from the floor? Dr. Birk.
Thank you, Paulina. I think it's important messages that you just delivered. Question, is this dispatched to all the European members to translate this into their native languages, or is there nothing so far happening in that direction?
That's actually a good question, because no action has been taken into that, but of course languages are a bit different, because for example, in Finnish, it would not be stigmatizing to say the other way around. So you don't have to use patient first language. That would be different. But I think that's a very good idea for the other terminologies that we could actually aim to enhance the implementation. Thank you, Dieter. Good idea.
Paulina, can I ask you? There are extremes. You've got, as you said, the stigmatizing language. And then you've got, I don't know if they're here, what they call healthy at every size, where you've got people saying living in a larger body, etc. When you talk to different groups, okay, with scientists we use this language, but when you talk to the media, do you change your language? And if so, what do you say?
That's a very good question. I would say that I personally try to use these terminology, but sometimes it has to be adjusted accordingly so they understand. But it's like, I think still that you have to have that idea in the back of your head that you're sure that you're not using any stigmatizing words in that context. Thank you very much.
Paulina, just to stress how important it is what you did, also the differences in different countries. For example, in Italy, it's an example, it's not better or worse, just to let the people know, the patient organization asked us not to say patient with obesity, but person with obesity. So it's still one step ahead or a different step.
Yeah.
And I think that what Dieter pointed out is a good suggestion for the board to
Definitely,
go
and
ahead.
exactly, and I think the patient organizations need to be involved in these. Thank you very much.
Thank you, Paulina. And you clearly thoughts are words and words are thoughts. And on that topic, Eric Stenberg from Sweden is going to use some terminology used in the cancer context, and will talk to us about neoadjuvant and adjuvant pharmacotherapy. Eric is also the vice chair of the scientific committee, so largely responsible for a lot of what we're experiencing today and the next few days. So thank you, Eric.
Thank you, Dimitri, for the introduction. Now, I have no conflicts of interest that should be of relevance for this particular talk, other than that of being a surgeon, of course. Now, the quite promising results of modern pharmacotherapy, they do address one aspect of the mechanisms by which metabolic and bariatric surgery works. And as we've learned previously, they should not be viewed as in competition, but rather as even further up. Okay, good. They should be viewed as, it seems to, it's okay? It's okay? Yeah, they should be viewed as tools within a common toolbox of multimodal treatment. And in the context of metabolic bariatric surgery, they are of particular interest to optimize patients who are more complex, or for whom we may anticipate a much more difficult and dangerous procedure, and after surgery as adjuvant treatment in the context of a situation where we have a patient who have a response to surgery that they are not very happy about, and that we as medical personnel are also not happy about related to the weight. Now, first, in the context of neoadjuvant pharmacotherapy, that is before performing the surgery, this report coming from the US quite recently suggested or reported that the incidence of people in the US living with obesity with a very high BMI classes seem to increase quite dramatically. And these patients benefit definitely from metabolic bariatric surgery, but performing bariatric surgery in this context is more complex. It takes longer time, it is associated with a much higher risk of complications, and it definitely reduces recovery after surgery. So in this context, neoadjuvant pharmacotherapy is an appealing approach. And the duration of such a therapy, how we do it, how we design this therapy can be individualized based on the patient's needs. Now, most of the weight reduction seem to occur within the first 6 months of treatment, with a slight but additive effect in the months to come after that, up to 1 year after the initiation of the treatment. After that, there really seems to be not much benefit for the patient. As you would expect, when we give the patients the GLP-1 receptor analogs, and we withdraw it at the time of surgery, you would expect to have no additive effect in the long term, which this study also supports. But what it does show is that we actually move part of the weight loss from the post-operative period into the preoperative setting, and thus we create a situation where we can perform surgery possibly easier, more smoothly, and improve the recovery for the patients, and transform a quite complex clinical situation in something that we can manage. And these results have been repeatedly seen in several other studies as well. So we can move part of the weight loss from the postoperative period to the preoperative setting and improve the situation for our patients. This is an example, just to highlight that. This is a patient who had a very high weight. He was treated in a multidisciplinary approach, but still he had a weight of 315 kilograms. So this was considered a quite difficult situation and a high risk to perform bariatric surgery. But he received semaglutide and a multidisciplinary treatment for 6 months and lost 50 kgs of weight, plus an additional 15 kilograms on the very low-calorie diet in the immediate weeks before surgery. And as you can see, the liver is still slightly enlarged, but the operative conditions are quite manageable at the time of surgery. Now, one concern that has been raised in relation to surgery when patients are on the GLP-1 receptor analogs is that these medications reduce gastric emptying. And there has been a concern from an anesthesiological point of view about residual gastric contents, which is much more common when surgery is performed. However, more recent data have suggested that the risk of aspiration, which is what we are afraid of, does not seem to increase. So from an anesthesiological point of view, it seems safe to continue this treatment. But when we do gastric surgery, this is not a situation that we want the stomach to look like when we perform surgery on the stomach. So there are no real clear science to guide how we should consider this, but from a practical point of view, you may consider withdrawing the GLP-1 receptor analogs at the time when patients are prepared for surgery, when they start their preoperative diet. That's just an opinion, of course, but it seems like a safe option. If we then consider the adjuvant situation after surgery, the pharmacotherapy is of particular interest for patients who have a suboptimal clinical response and for patients who have recurrent weight gain. Now, how many patients this concerns depends very much on how we define the situation. If we use a very liberal definition of a recurrent weight gain of 30% or more from the maximum weight loss, this may in fact be concerning about 45% of patients after a Roux-en-Y gastric bypass based on this Norwegian data. On the other hand, if we use a very tough definition, looking at the patients who still have a benefit from their metabolic bariatric surgery, that is patients who has lost 10% or more, then there will be very few patients after Roux-en-Y gastric bypass who do not achieve this goal, and slightly more after sleeve gastrectomy. But that's a very hard definition, and I don't think most patients will not be satisfied with this weight loss. If we use a more reasonable definition of a total weight loss of 20% or an excess BMI loss of 50%, this will concern about 20% after the Roux-en-Y gastric bypass and double that after the sleeve gastrectomy, at least based on Swedish data. So we saw this study, the results of the BarryOptimize study previously, and this concerns then mainly patients who have previously been operated with a sleeve gastrectomy and have a suboptimal clinical response. And as you can see, they benefit a lot in terms of weight loss when adding modern pharmacotherapy, in this case liraglutide. But then on the other hand, for the sleeve gastrectomy, we have another option. It's quite safe to convert a sleeve gastrectomy into a Roux-en-Y gastric bypass, and the results, at least to me as a surgeon, may be more durable in the long term, and this may be an alternative. On the other hand, if we look at the Roux-en-Y gastric bypass, revision of a Roux-en-Y gastric bypass is much more complex. It's a more difficult procedure, and their complication rates are much higher. And here, data on pharmacotherapy mainly relies on observational studies with the limitations of a very short follow-up extending from 3 months in many studies to a maximum of 2 years follow-up, which is quite short when it comes to a chronic disease. But again, if we look at these studies, you will see that the weight loss results reported in these studies are quite good. And with the more modern pharmacotherapy, they approach that you would expect and see in patients who have not undergone bariatric surgery previously. One concern is then to maintain treatment, and that is to a large extent patients drop out either due to high costs, and that is, how to handle that is mainly a political management that we don't really control, and for hopefully in the future the medications will become cheaper and that will not be a major issue. But the other reason as to why patients stop taking the medications is due to adverse events. And a large proportion of these adverse events are gastrointestinal, and many of them tend to disappear within a few weeks of treatment. So for us, or for those who start this treatment, it's very important to support patients and to inform them well during the initiation of this treatment to maintain a long-term adherence. So in summary, pharmacotherapy seems to offer an appealing alternative or approach in a complex situation in the neoadjuvant setting for the most complex patients that we see, those with the highest BMI. And in the post-operative settings for patients with suboptimal clinical response and those who experience recurrence in weight. Thank you.
Thank you, Eric, and thank you for using the precise language. You didn't have to wait for 17 years to start doing that, so that is highly appreciated. Question?
Yes, thank you, Eric, for this very nice overview and presentation. I don't know if you read this paper published in Nature about the set point of obesity and the concept of the memory of obesity and the concept that there is for one patient, there is a set point and it's difficult to go under. The body will try always to go to the maximum weight, but you cannot go down to this set point. Do you think that adding pharmacotherapy to surgery can help to move this set point?
Well, thank you for the very difficult question. And of course, the answer will be based only on opinion. We know that surgery changes the set point. My personal opinion is that this does not change the set point. But I'm not sure what others will say, but that is my personal opinion.
Whilst we are on difficult question territory, if we had to focus on future research questions and you can only focus on one, neoadjuvant or adjuvant, what would be your favorite?
I have to choose between the two? Okay, as a surgeon...
It's not supposed to be easy.
No, that's a very difficult question. No, I believe that the neoadjuvant, in the context that if we believe that Europe will follow the United States, we tend to do that, at least in Sweden, with a delay of a number of years, we will then also see a higher number of patients with very complex situation. And in that situation, I do believe that modern pharmacotherapy offers something very important for surgeons. So I suppose that would be my choice, but I'm excluding something also important then.
Yeah, of course. No, it's just the difficulty of single one. That's great. Thank you.
Just a comment. Well, yeah. As far as terminology is concerned, in obesity medicine, we tend to use incretin-based therapies for pharmacotherapy to cover all the receptors, because it's not only GLP-1 receptors, so and there are more to come, 2 receptors, 3 receptors, maybe 4, I don't know. And as far as the language is concerned, in my language, which is Turkish, we tend to say obesity medicine. It's easier for us. We can't say obesity management medication. We say obesity medication or obesity medicine. So it's right. It may differ from language to language, but we don't use anti-term anymore.
Can I respond to that, actually, on the incretin-based treatments, which I completely understand why we use it, but my challenge with that is that we are not using the incretin effect for most of the therapeutic targets. So when we're using these treatments for obesity care, the incretin effect may not be, it's not always relevant. It is relevant in the context of type 2 diabetes, and it's relevant in the context of insulin resistance, but it is not relevant to appetite and weight loss. So I struggle sometimes to use that term on that basis. And I appreciate that's different from what we're discussing now, but Alex, you may have a response to that.
Therefore, can we stop doing that? Can we stop using the term incretin therapies? Can we, probably a better term, for now at least, is gut hormone therapies, because that encompasses both gastrointestinal hormones and pancreatic hormones, because they're part of the GI tract. As it, gut hormone is much more inclusive of what we are doing and what we're going to be doing over the next few years. Obesity pharmacotherapy is fine, but again, that incretin, I also find it difficult to understand because, okay, it is for GIP and GLP-1 only, because these are the only two incretin hormones we know. That's a small point, but I think we might want to start changing that language.
Thank you. It says that there's a lot more to be discussed.
Now, providing that Paulina remembered us that you need 17 years to complete an RCT, and with the overwhelming introduction of the new drugs, how should RCTs adapt in the pharmacotherapy era is a tough question, and the answer is by Paul Robert from Lyon.
So thank you very much for the invitation. Yeah, indeed, it was a difficult question, but very interesting, and I will try to answer that. So probably the real question is that we are moving from weight loss trials to strategic guiding trials. So why the classic RCT model is no longer enough? The old RCT paradigm was a comparison, procedure versus procedure, drug or versus placebo, drug versus surgery, short-term weight loss most of the time in a selected population. So these were procedure comparison trials. If we look at the new reality, we have multiple drugs rapidly expanding. We have a really chronic disease. We now all know that obesity is a chronic disease requiring sequential treatment. We need long-term clinical benefits, individualized care, and we are moving to precision medicine. So we are now dealing with multimodal chronic disease strategy trials. So what surgical RCTs taught us? Randomization reduces bias, standardization improves validity, multi-center trials increase the applicability, and evidence changes practice. So now we need RCTs that build treatment algorithm like we have for type 2 diabetes. We have algorithm. We also have algorithm to treat hypertension, myocardial infarction. So we need that for obesity, as it is one disease, but we have many options. We have lots of drugs with future agents that are coming. We have multiple types of surgeries. We have also endoscopy with ESG. But the key unanswered questions are numerous. Which drug first? When surgery? And we had Eric showed us this, looking at weight loss strategies after stopping obesity management medication, and when you perform surgery can change the weight loss strategy. We also have unanswered questions regarding which patient treating, based on which comorbidities, based on which tolerance, on phenotype and morphotype. So from weight loss to clinical outcomes, this is what we have to do. Beyond weight loss, we have to focus on cardiovascular events, on mortality, on diabetes remission durability, on quality of life, of functional outcomes, and the treatment burden. So we have to move toward hard outcomes, and this is already what did the drug trials like SELECT trial or SURPASS trial, which are RCTs assessing prevention of cardiovascular death. And we also have, regarding metabolic and bariatric surgery, meta-analysis, which evaluate the cardiovascular risk. So what are the limits of weight? We now know them with this publication redefining the obesity as a clinical disease. In this publication, we have this example, like 3 patients who have the same BMI, 32. One is an athlete, he has a good I mean, he's in a very well fit, he's metabolically healthy, and we have 2 other patients, one has preclinical obesity, probably metabolic disorders, and another one with the same BMI who have clinical obesity with type 2 diabetes, probably a MASH, or a history of myocardial infarction. So BMI and weight loss are surrogates, but they don't assess the severity of the disease and the efficacy of the treatment. So what are the limits of current pharmacotherapy randomized controlled trials? They focus on very selected populations. In this trial, most of the population are patients with no history of previous bariatric surgery. They are limited to perfect patients, most of the time excluding very complex patients with very complex pathologies. There is a high adherence because most of these trials offer the drug, so they have free drugs, which is not the real world. We all know that patients have difficulties to pay for these drugs. They also have limited long-term discontinuation data. So how RCTs should adapt right now? Probably compare strategies, not tools. For example, surgery alone versus surgery plus drug, or drug first versus surgery first, or what presented before me, Eric. Stratify by phenotype. Do we include patients only with type 2 diabetes? What are the cardiovascular risks before starting the trial? The symptoms, GERD, what are the grade of obesity? Also, we need to use long-term and hard endpoints like data over 5 or 10 years of follow-up, the major adverse cardiovascular event notion, and also we have to speak considering survival. We have also to integrate adherence. What are the number of discontinuation? Were they switching from procedures to another, or from a therapy from another therapy? We have also to consider rescue strategies. And we have to be pragmatic. We have to use real-world populations who had, for example, prior surgery, not patients with no surgery, like we can see in the pharmacotherapy RCTs right now, patients who have complex comorbidities, and we also have to do medical economic evaluation. So the kind of RCTs we now need are probably algorithm trials, which drug for which patient, combination trials, neoadjuvant, adjuvant, concomitant, rescue trials, what to do after insufficient response or weight regain, and outcome-driven trials. We have to focus on cardiovascular events, survival, and long-term control. The future is how to combine and sequence treatments intelligently. So take-home message of this talk, RCTs must evolve from efficacy to applicability, from weight loss to clinical outcomes and survival, from one-size-fits-all to personalized algorithms and precision medicine, and from tools to strategies. The best trials will not tell us which treatment is best, but how to use all treatments together to improve long-term health. Thank you.
Very, very clear. Thank you very much. Question from the floor, even if questions are rather difficult on the topic. I have one for you. You clarified very well the classical model of RCTs, which are, in a sense, well established, so we know what they are. Now you depicted correctly what are the new frontiers. Do you think that this complexity will be another obstacle for scientists to start an RCT. I think reducing the chance to have an RCT, including the fact that not everywhere the drugs are for free.
I think, yes, it's increased the complexity of designing a trial, but I think that using, for example, QALY, medical economic evaluation, can help to redefine really what we want to for our patient and what the society is able, to afford to assess the efficacy of the surgery and the drugs and the treatment in real life. It's difficult to answer, but yeah.
You touched on it. RCTs are very expensive, especially when you're going to do surgical combined with pharmacotherapy. Who's going to pay for them, and how do we work that out?
In France, the government is paying for these trials, so you have to apply for a fund, and it's not easy. You can also apply for the European funds. We can also use the industry. I think that there is a trial right now comparing drugs to surgery, using fundings from associations and from the industry. I think money is everywhere, so just have to apply and find it.
To ask you a question on the theme of difficult questions. There is distinct lack of diversity in pharmacotherapy and surgical RCTs in terms of population. The vast majority of participants are Caucasian and female. We clearly need to do better. How do we do that? And I'm asking you as a trialist who's delivered these amazing RCTs, how do we do better?
So we should do the trials before, as doctors, and not trials driven by the industry. The industry want to show wonderful results, and they're probably why they try to select the perfect patients. So these trials have to be conducted by us, and so you can define which population you want to analyze, like patients who had already had previous surgery, patients who are old, patients who had sarcopenia, patients who who are who have type 2 diabetes. I think this is us who should lead these trials and design them.
Other questions? If not, Maud, thank you so much. We go ahead.
So, last talk of this session, clear question to Torsten Olbers. What are the trials we need to start yesterday to solve all this?
Thank you very much. Good afternoon. Everybody's longing for a cup of coffee, aren't you? But keep a little bit with me. I was very, very honored to be invited and slightly terrified by doing this, that you kind of, it's hard to predict, especially about the future. But I will try, and I would just say that many of these thoughts are obviously just my interpretation of things and my thoughts for the future. I don't think I have any. Anyway, these are my conflicts of interest. What do we need to have a breakthrough with studies that is actually getting into practice? To be trusted outside the surgical community, we need to have a good study design. Of course, we need to have that. We used to come from patients were like this before we operated them, and patients were like this after. No one outside surgery trusts that properly. We need to ask the questions before we do the study. We should not go back to a data set too much to fishing after things we want. There's a place for that, but we should ask the question and design the study according to that. And I just want to stress this, that the trustworthiness of a study to have an impact is that you have a good control group. I think we have underestimated that heavily in the surgical community. We just show results, but we just need to have a good control group to see what's happening if you don't operate. Registries coming from Sweden with Eric and Johan running the SOREG is very, very good. A good registry is a gold mine to do studies. And I think also that we should do well-established and standardized procedures when doing surgery. Somebody mentioned the cowboyish part of us surgeons, that we need to kind of narrow down to a few procedures that we really know what we can deliver. Maybe just one or two. We have some solid data, mortality, cardiovascular events, cancer, and long-term weight loss. Without the SOS trial from Sweden, we wouldn't, with the internist Lars Sjöström, we wouldn't be where we are today. That's been a real milestone in this, delivering those results over 20 years, and now even 30. I just want you to have, as surgeons, I think we should look into what are pharmaceutical companies doing, and what are their strategy. I just had a PubMed search, and this is quite impressive. I'm just picking New England because it's the highest impact journal. These are semaglutide results since 2019, I think. And if you look at what are the endpoints, it's not just weight, of course. You have to show in some studies that you affect weight, but you're going to comorbidity after comorbidity and showing the benefits of this. And you go to different groups, you go to adolescents, and this is the strategy. And if you go to tirzepatide, they're doing the same thing. They're just producing this, and they have designed those studies. So I think to keep up, we need to look into that. And as was mentioned before also, I think these are obviously things to come in the medical trials, that we can affect mortality. But I think also that cancer and cancer prevention would be a strong endpoint in future studies. I think Maud mentioned this, but actually a study that started yesterday that I want to do. And we were fortunate enough to joining that study. This is the Lightcom consortium led from Copenhagen University, teamed up with Oxford, and there are 3 projects in this. But a study called LightBar, where we started out in January, and we have close to 20 patients randomized in Sweden now, and in total it seems to be around 150. And it's an RCT between best surgical treatment. It's patients eligible for having bariatric surgery. They are randomized to either undergo surgery or having optimal medical non-surgical treatment with low-calorie diet first, and then you introduce tirzepatide. So this is kind of a study that takes a lot of resources, but I think it will deliver some kind of non-biased compassion in this. I lost my slides here. Okay. Maybe I'm out of time, I don't know. But I lost my, thank you. Let's see here. Where were we? It was this one, yeah, it was. So a little bit of a wish list for studies in metabolic and bariatric surgery that I would like to see. I think according to what we see with the medications, I think there's just an open door to do, for example, obstructive sleep apnea, randomized to best surgical or best non-surgical treatment, and looking at the relevant endpoint. Maybe getting out of a CPAP, not having the the proportion that don't have a CPAP. Also, arthritis, knee arthritis, osteoarthritis, that could be something. I think there's really some low-hanging fruits that we could pick up to tick some boxes in this. I think also we should not oversee the possibility of when we have good registries and good reliable data in registries, we could actually compare to other registries that are good. Fortunately, we have good registries in Sweden, and many of you have been involved in this way, compare diabetes registry and the surgical registry. I think we need good design study to have MACE as endpoint also to show that we actually do that compared to some kind of more modern medical therapy. And as I mentioned before, cancer incidence is likely a good endpoint to look at, because that seems to be with the improvement in cardiovascular treatment, I think that cancer will stand out. That's a guess, that cancer will stand out as the mortality driver of obesity. Okay, here's again the wish list. I say this again, that study design, think before and not just looking, what have I done, and then I'm going into my data. Spend the time to see what study should be done. Pick the control group beforehand, so you have something to compare to, not just before and after. And use your registries and establish your registries, because that's trustworthiness also for what you're doing in the country, isn't it? That you can show what levels of side effects, for example, and complications you have, and use the standardized, well-established metabolic bariatric surgery techniques. This is a phrase I'm using quite much, that we shouldn't be kilogram hunters. And we have been a bit of that historically, that my 40% weight loss is better than your 30, and it was mentioned before also. I think we should go to what many of you are saying, that we should treating to target. We need to have a target for the patient. We are not just applying the same target for all patients. We should define what do we want to achieve with our treatment. And just the last slide here, that I think we need to be complementary, and in that way I think that lifestyle can be a little bit of a lonely fiddle. But if you have a pharmacological therapy, at least now it's a string quartet where you get another sound and you get more to have. But my perspective is that a Roux-en-Y bypass is a good functioning Roux-en-Y bypass is like a symphony orchestra. It works on very many strings, and many of them we probably don't know currently how they are. So thank you very much from the top of my head.
Thank you, Torsten. I see there's some movement in the room, so please, Alex.
I think one of the problems, if we are to compare medical therapies with surgical therapies, even for hard outcomes, is that we are unlikely to see a difference. Yeah? That makes the trials a little bit less sexy in terms of funding and in terms of publications. But does this mean that we should become more comfortable with non-inferiority type of trials? They might have, both groups achieve the same benefit, for example, but they have a different experience, they have different requirements, different side effects, different costs. Is that something that you think could fly in non-inferiority?
If I'm standing on the side to kind of consider the role of metabolic bariatric surgery, I think we somehow need to prove that we are slightly better at some endpoints than medication. Otherwise, people will look at medications and say, why not having medication? So from that perspective, yeah, maybe that we are non-inferior. I think just sometimes we can probably design studies at least in large-sized registries to look at the hard endpoints that we can get cardiovascular. And I just think that we discuss more about that, how to use the bigger data, that we don't do a smaller randomized study, because that will not show. But yeah, I got your point. It's good. For example, in BEST, we have another way of looking at it. We show that we have 1,700 patients randomized between sleeve and bypass. Then we looked at all the patients at the centers that were including in BEST. That was 8,000 patients. And then we looked at all practice in Sweden over that time. Then we have 20,000 patients. And fortunately, the demographics and the outcomes from the operations were pretty similar. So we can scale the questions in that way. This is,
yeah. We seem to be plateauing in terms of the surgeries available and also even though pharmacotherapy. To answer your question, should we have been looking at the cost effectiveness of treatment earlier and included in all studies? The reason is I work in a health system where some of the biggest barriers to treatment are really getting government agencies to pay for the treatment or getting insurers to pay for the treatment. And I don't think we've got good studies in terms of looking at cost effectiveness because we're treating end organ issues at the moment rather than the primary issue. And I think that's something that we should probably have been doing from the start. Any new trial needs to be looking at, compared to standard treatment, are we not only getting better results, but is it more cost effective to the system and is it actually saving money?
Yeah, that's probably a good question right now. But if we're looking at, we are getting the results in 5 and 10 years, and then we will have a totally different price scenario of the medication. So that was a little bit with the omeprazole, when that came for reflux. We said that a fundoplication was cost effective, but then it just took 5 years, and then it was not cost efficient because the price has dropped. So I'm not sure about the price issue of designing studies now. I wouldn't have done it myself because I foresee that this will be less of an issue in the future. But maybe I'm thinking of rather quality of life and other issues than just mortality, cancer. What kind of life are you living with a good operation compared to having medications for decades in the future?
Torsten, I'm going to ask you another difficult question. In an era where pharmacotherapy and obesity care is evolving rapidly, and we know that doing an RCT takes time. It takes time to design it, time to go through regulatory processes, recruit, and then having outcomes. I do worry even about LIDEBAR, that we're working together on that by the time you report, the field has moved on. And we will have, how do we innovate and how do we do clinical trials that will be time-proof, that will be still useful by the time of the report?
Yeah, it's a good question. And I've done some philosophy about that. I think that you will never have a time-proof study. Things will change. However, you will need to start digging where you are. If you don't design trials and do trials, you can't change practice. I'm giving you an example from the BEST trial, sleeve and bypass, that we did. That in the beginning of the BEST trial, we couldn't include patients because everybody wanted a sleeve. All patients requested to have a sleeve. In the end of the BEST trial, we couldn't include patients because they don't want a sleeve. They wanted a bypass. So this is kind of, I think, just by doing good studies, we are improving practice and we are gaining knowledge. And we are seeing, and Volkan, I think is extremely good if we can join into studies to see the same outcomes in front of us. So not the internists are sitting there doing their studies and we are sitting there doing the surgical studies, that we can actually see the same picture in front of us. Yeah, that's just some kind of answer to that question.
Okay, then we'll have to conclude this session, and I want to invite everybody back in half an hour for the quiz battle in this room.
Yes. May I ask the speakers to come here for a picture?